More people are choosing hospice care, and they're living longer than their 6-month prognosis. And that's become a problem for Medicare.
Curly, curly, curly hair.
Yes, I remember you have.
I look at those pictures and look at all this thread, and where did those curls go?
It was pretty.
The first time L.C. Solis danced with Betty, he knew she was the girl he'd marry.
And then this was our wedding.
Now, 66 years later, L.C. and Betty Solis look back on a marriage, a lifetime really, without regret.
Can't complain about nothing. Really, if I did, I'd be a fool.
L.C. is 89 years old. He's dying. He has stage 4 heart failure. His breathing is labored. It's difficult for him to walk from one room in the house to the next. The constant pump of the oxygen machine reminds everyone in this house L.C. is not well.
Nice and deep.
Congestive heart failure, L.C.'s condition, is one of the most common reasons people over 65 are hospitalized. But L.C. hasn't been to the emergency room in 2 years. Instead, he's chosen hospice care.
How are you doing today, L.C.?
Oh, pretty good, Doc. You?
Good. I'm doing just fine.
On this day, he's being examined at home by his family doctor. He also gets regular home visits from a team of nurses and therapists. His symptoms are being palliated. That means doctors can't reverse his condition or make him better, but they can make him comfortable as his heart grows weaker.
Deep breath in and out. Again.
To be eligible for hospice, a patient must have a terminal illness and 6 months or less to live. When Medicare introduced the benefit back in the 80s, most hospice patients had cancer. Today, the most common conditions are those that make predicting death difficult. Suzi Johnson is the vice president of Sharp Hospice.
A patient with a chronic medical condition, debility and decline, dementia, heart failure, end-stage kidney disease, things that are medical, pulmonary disease, Parkinson's, go on and on. Their trajectory is different. It's a slope that takes time and a lot of time. And then they begin to decline, boom, 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 like this. And then they go.
Across the country and in San Diego County, more people are choosing hospice. 10 years ago, 10,600 people were treated in hospice in San Diego County. In 2011, that grew to nearly 14,200. While the majority of people in hospice die within the first month, there are a growing number who live past 6 months. In San Diego County, 1 in 9 outlived their 6-month prognosis in 2011. And every day they're in hospice costs the government money. Under pressure to save money and find fraud, Medicare wants to know, were they really dying? San Diego Hospice, the largest in California, has been the subject of a Medicare investigation for the past 2 years. Kathleen Pecure is head of San Diego Hospice.
We've narrowed the window of patients that we take on, because we're so specifically looking at it through a very strong lens of compliance.
San Diego Hospice has even discharged patients they now deem as ineligible. In other words, not terminal. Experts are asking whether it makes sense to limit care for a growing number of elderly, chronically ill patients who would benefit from it in the last year, even 2 years of life. It begs the question, when does end of life begin?
How do you take care of patients with advanced illness that may be close to end of life, but maybe not terminally, may not fit into that eligibility perfectly?
Kathleen Pecure and Suzi Johnson would both like to see a change in the rules, allowing the chronically ill to have access to hospice before the final 6 months of life.
A benefit of 12 months or less, assuming the normal course of the disease. That might be more appropriate, considering patients live longer with chronic illness than they did when the hospice Medicare benefit was instituted in 1982.
L.C. has been receiving hospice care for about 13 months.
Yeah, like I asked you once before, how long you think I got? And I know you don't know.
I will tell you the same thing I said. If I had 100 people in your situation, some would be here for many months, and some would be here just for a few days.
Yeah.
So we just got to be prepared.
LC is allowed to continue hospice care because his condition continues to get worse and his prognosis hasn't changed.
He can't go much farther with much more fluid, and his heart's going to fail. He is getting every last breath out of life that his body will give him.
And I think he's waiting to turn 90 years old the 2nd of April.
He's going to be old. I don't think I'll be here.
Well, we don't know. You've surprised us so far. We just
Well,
have
Doc
no idea.
don't think I'll be here either.
Well, he doesn't know. He's guessing just like we are.
Joining me to talk more about hospice care are my two guests, both of whom you saw in the story. Suzi K Johnson is Vice President of Sharp Hospice, and Dr. Daniel Hoefer is a family physician and Chief Medical Officer for Sharp's palliative care program. Thank you both for being here.
Thank you.
So, Suzi, why are more people choosing hospice care?
I think it's becoming mainstream. Physicians are learning how to refer to hospice, and I think patients and families are wanting it and asking for it.
And have you at Sharp experienced this increased scrutiny by Medicare with regard to who's actually eligible for the benefit?
We have, and we're doing well. We're following the guidelines and the criteria and document accordingly.
Now, Dr. Hoefer, the story really tried to kind of highlight this gap that exists. As people grow older, they get sick, maybe 2 or 3 things are wrong with them. They're looking at hospice because it's a kind of care that, you experience it at home. It can help you live longer. What do you do to address this gap? If you can't put somebody in hospice care, provide this care because they're not terminal, what do you do?
Well, in the traditional healthcare model, there's not a whole lot. Patients have to have a Medicare Part A skilled need to get home health, or they simply have to move into an institution to get any level of assistance. What are called ADLs, bathing, grooming, dressing, toileting, transferring, and feeding, they're not covered by any insurance plan. The family has to pick up those costs, but that's a part of the natural decline of every illness. Now, some it happens earlier, like dementia, but it happens later. And so we don't have a good system right now to fill in that gap.
Now, Suzi, Sharp has created its own benefit, really called Transitions. Tell us more about that.
The Transitions program, basically we took our knowledge of hospice care, our use of the IDT, interdisciplinary team, using prognostic indicators, etc., and we made a program for people who are in late-stage illness, heart failure, COPD, dementia. Now we've gone on to advanced stage cancer, where really we're providing a consultative service at home with a nurse and a social worker, really doing disease education and goals of care discussion and getting people prepared for what's coming next. It's not the if this happens, it's the when. We change the conversation, and that's, I think, what you saw with LC and his wife. They're really prepared for what's happening next. There aren't any surprises. That's what we've done with our palliative care program. There isn't funding for that in traditional Medicare, but in the Sharp healthcare system, where we manage our own population-based management financially and also medically, we're able to provide that service to our patients.
What really surprised me when we talk about hospice care or even transitions, that these are simple things that you're teaching patients to do at home that actually keeps them out of the hospital. You're teaching them how to take their medication, maybe increase their dose, not to retain fluid, so you take this pill instead of that pill. Correct. Is it really simple things like that, just having that home consult that can keep someone out of the hospital?
About 2/3 of readmissions, which is what the big issue is with the ACA, the Affordable Care Act, for hospitals, we found that those readmissions are based on medication mismanagement. Well, guess what? Good medication management also improves symptoms. And so by going in and helping people manage these issues, and sometimes they are very simple, we can help people do a better job. On the other hand, I cannot overvalue the importance of family moral resolution, that they understand the pathway that their parents are on. Because what happens in the traditional system is that these patients decompensate in the ER or the ICU or the hospital, and then the family shows up, the distant daughter or relative or son who hasn't been involved in their care except over the phone, asking how mom and dad are doing, and moral resolution occurs while the patient's intubated in the ICU. That's a reactive model of healthcare. And what we need to be talking to our geriatric patients and their families about is proactive management and the inevitable consequences of the best that the healthcare industry has to offer. We will do whatever you want us to do. But guess what? The patients are speaking up and saying, I just want to be at home with aggressive in-home supportive care.
We're going to have to end it there. There's a lot more about this issue on our website at kpbs.org. Dr. Daniel Hoefer, Suzi Johnson, both of Sharp Healthcare, thank you both for being here.
Thank you.
Thank you.